Bill went on to an academic career at the University of Michigan from 1993 to 2007, and then Nationwide was fortunate to successfully recruit him to his current home at both Nationwide and Ohio State. In terms of scholarship, it's really interesting what Bill is talking about today, because those of us in pediatric nephrology know Bill as an internationally recognized investigator whose work really spans the translational spectrum. At the bench, he's a podocyte biology and glomerular disease person. He works also on biomarker development, and in the clinic, he works on glomerular disease issues and trying to help us increase our understanding and improve our therapies. Had extensive research funding from the NIH and foundations, and importantly for our field, he was the co-founder of the Midwest Pediatric Nephrology Consortium in 2004. He has lots of recognitions, lots of awards. He's been a best doctor in America since, God was a pup. Nationally recognized thought leader in leadership development, and that's Bill, but he's not going to talk about any of that today. So Bill, in the course of sort of thinking in the laboratory and thinking on the wards and thinking in clinic, was like, why don't we ever put this together? Why do we not learn from what we're doing when we have these really smart people around? And so there is this concept that has emerged, say, over the last decade or so, of the learning healthcare system. But it's all theory, and as my sister very disrespectfully says over and over and over again, it's all blah, blah, blah. What does it really mean? So Bill set about doing a pilot study that he's going to tell us about. It was the implementation in a local context to have a learning health system at Nationwide Children's, and it's to fuel meaningful improvement across quality, experience, engagement, and financial outcomes so that we do a better job taking care of our patients based on the knowledge that we accrue by taking care of our patients. Doesn't that sound cool? So Bill's going to tell us about that. Bill, welcome to Children's. We're really looking forward to your talk.
Well, thank you very much, Lisa, for the kind introduction. So what I'd like to talk to you about is this challenge that I was given about 10 years ago when I got recruited to Nationwide Children's. The board challenged us and said, you have one of the largest pediatric hospitals on one side of campus and one of the largest children's research institutes. What we don't see is how you're using all that new knowledge to improve the care. So originally when I started thinking about this, it was because I thought that's what I was getting paid to do. But it turned out to be actually a somewhat of a disruptive innovation, although not intentionally. So what I'd like to do is spend the next 45 or 50 minutes sharing with you this journey that I've been on to try and connect research and clinical care as a matter of standard provision of care, not as two separate processes that are going on. So I'll start by summarizing what we all know well, which is some of the trends and the barriers to integrating research and clinical care. I don't know of an organization that's not trying to do this, but I also don't know of an organization that has mastered it. And then what I'd like to do is suggest a paradigm shift in how we think about learning health systems and talk about a bottom-up approach from program to program rather than a top-down approach about how we can connect EHRs across the country. And to do that, I'll describe for you this program model that we've developed called Learn from Every Patient, and I'll share with you the experience that we had in actually trying to implement it and measure whether it could actually improve care and whether it could reduce the cost of care and whether it could do them both together. And at the end, I'll share with you what we think that we have learned from it, and more importantly for you all, what we think the opportunities are for all of us based on models like this. So probably over the last 10 or 15 years, most of us are aware that there's been a convergence of some major trends in medicine. We've all had the opportunity and or mandate to convert to electronic medical records. There's also been a huge push for us to move into clinical and translational research. The CTSA program implementation is a little over $500 million that has gone into supporting this and encouraging it. And as we all know, we have an ever-increasing need to control healthcare expenditures. So we spend 18.3 or 18.4% of our gross domestic product on healthcare. and that number is going up every year. So there's major issues around some of these trends. So these trends have actually culminated, though, in what I think are some unprecedented opportunities and some unprecedented interest to try and develop systems that can actually improve care while reducing costs. So you all may be familiar that what used to be called the Institute of Medicine put forward a challenge, originally probably 10 years ago, that this is what we need to do, is create systems that can learn from their operations, not as a side effect of their operations. What's also particularly interesting to me is, as I dove into this area, there is a not-for-profit bioethics group called the Hastings Center, and they actually published a series of papers, and in a few of them, they actually called out the fact that over the last 30 or 40 years, we as a society have purposefully separated the provision of care with a whole set of rules and regulations and now laws around how we provide care and how we generate new knowledge, which ostensibly is to improve care, which has a whole different set of rules and regulations. And a few of the authors made the case that we have done that artificially, and in fact, we owe it to our patients to undo that, to connect them back so that we can use the care that we provide to improve the care for them. So why, if everyone is interested in doing this and there are all these opportunities, why hasn't this happened? Well, there are a lot of barriers to this, and I've been talking this morning with leaders in your organization who have echoed what I've heard all around the country about the barriers. One of the most important ones is most places have inadequate organizational readiness. The one that's most obvious is the infrastructure related. We're not quite set up to do that. But the bigger reality is that for most of us also there are financial and or political barriers to actually having the willpower to change the way we provide care in the service of trying to improve care. Most centers also experience inadequate information standards. It may be differing terminologies, but it could also be different data models or even data architectures. Inadequate technology integration is an issue. I remember several years ago when I first got to Children's, I would work on the clinical side and on the research side, and we had different versions of the same software. So when I logged in on the clinical side, I couldn't work on the same document that I was working on because that was a research program, not a clinical program. And last but definitely not least is the barrier of inadequate workflow integration. So how many of you have been involved in research? Most, okay. So those of us that have both provided clinical care and done research are ever so aware that the entire culture around how we provide care versus how we do research is completely different. I remember the person that hired me as a junior faculty said to me one day during my first year, "Oh, you're going to go escape to the lab now." But really? Okay, well that's one way to look at going back to the lab after serving in clinic. But the processes and the cultures around these two activities have historically been very separate. So why is this? Well, it's not like there's a bad actor or people come to work trying to keep us from making progress. And in thinking that through in detail, what I developed was this table that actually highlights the issue, which is a misalignment of people's primary interests. And on the left here, I'm not going to go through these in detail, but there are a number of stakeholders who have a role in a large, complex medical center, in the running of a medical center. And here are just some excerpts of what their primary interests are. And you don't need to read it in detail. You can just look at the shape of this and see part of the problem is they don't all go to work trying to make the same thing happen. And in fact, sometimes one of the person's primary interests may directly conflict with another person's primary interests. So we don't need a bad actor here. We just need to recognize that the interests of all the different stakeholders involved in how we provide care for patients are not fully aligned. And I've created this cartoon to try and show this pictorially. So this current state, here are all those same stakeholders from the previous slide, and you can see that they're all connected, but they're not really connected in an organized way. And when that happens, you get what we have: inconsistent care, rising costs, variable quality of care, but importantly, in the current environment, overall poor value for the money that we spend on care. So what I'd like to suggest to you is an alternate paradigm. What could it look like if we imagined a future state with a paradigm where all these different people had different things that they did to work, but they actually knew that they were part of something bigger than them, and they actually wanted the same outcome to happen. And that's shown here. What if they all lined up? Well, what we think you could get would be better care, lower costs, better quality, and again, overall better value. And those barriers that I talked about on this slide are pictorialized here as what we call headwinds. These are somehow or another, this is not going to happen unless we can get over these headwinds: financial, political, operational, organizational headwinds. And so what we realized is what we really needed to do to get over the headwinds was create some sort of disruptive innovation. And so when I talk about a disruptive innovation, I'm talking about a way to provide care where we fully integrate evidence-based medicine with what we call evidence-generating medicine. The same medicine. The evidence, using the evidence is generating the future evidence. So what I'd like to spend the entire rest of the talk on is this, which is the center of this disruptive innovation, and this is this pilot program called Learn from Every Patient. So when we think about learning health systems, oftentimes we think about connectivity between the EHRs and how are we going to extract data. This is the antithesis of that. This is starting at the very bottom in one program, in one center, and saying, can we actually show that you can learn, let's say here, in Program A in Learning Health Organization number 1, and can they share within the organization what works locally there, politically, financially, operationally, so that other programs can apply it in other subspecialties. And importantly also, Program A here actually has a correlate in this other organization. They're taking care of the same patients, but their details are a little bit different. But the clinical part, the topic area is the same. So the idea here is that if we can generate learning within and among learning health organizations, that this can ultimately create from the bottom up what I'm referring to as a learning health system. All right, so with all of that in mind, we generated a very simple hypothesis. We theorized that a learning health system could be cost-effectively developed and implemented, and that it would systematically drive both clinical quality improvement and reduced costs. So the aim of our little experiment was to develop and implement a pilot program. Well, what would it look like if we fully integrated the research and the clinical care? And we tried to give it a self-explanatory name, so we called it Learn from Every Patient. So the mission for this, kind of stated another way, is to fully integrate the knowledge that we gain from the provision of care with research to systematically use it to advance care. And said maybe even a little bit more plainly, the commitment here was that we'll learn from every patient at every visit and use that knowledge to improve the care of the children that follow that patient. Very simple in concept. So this is probably the most important slide of the entire talk. So this is the program model that we used, and we found a group of doctors that were willing to change in one clinical program in our organization, and we challenged them to create evidence-based standardized care. You can never prove that something is better than what you have today unless you can measure the difference between it and now. And if you don't have your arms around what now is, you can't measure a difference, and you certainly can't convince a skeptical reviewer or a skeptical corporate suite person that it's statistically better. So you need to know from where you're starting to be able to say that something is better. So we got this group of doctors to commit to this, and we gave them the opportunity to improve the care of their patients. We asked them, what questions could I answer for you that you know would improve the care of your patients? Not my patients, your patients. And we went through a series of steps that I will detail to convert that into codable text in the electronic health record. So what that did is that took the doctors who normally are the most recalcitrant stakeholder in academic medical centers. They don't really want you to tell them to change how they provide care, and made them want the answers to the questions. All they had to do was change the way they documented the current care to have the opportunity to improve the care of their patients. Their questions, and we would give them their answers. So then all of this gets collected, this clinical and research data, but not in two databases. It's all in this thing that we call the EHR. It all gets migrated into a data mart. And then, as we do well in academic medicine, when we mine the data, we do what we call now translational research, and that generates new knowledge. And the way we measure that in academia is we publish papers. And those published papers are the evidence, and the publication in peer review is the currency of the realm to sell new ideas to people. People that run medical centers, people that pay for clinical care, people that certify new drugs as safe and effective, like the FDA. This is a very important currency. And usually in academic medicine, that's where we stop. But with this model, this model is not complete until that evidence then gets brought back around and fully embedded into the standardized care so that every single person behind that evidence that you've generated benefits from the evidence. And this is late-stage translational research or implementation science, as we talk about. So this is a model that, if it's fully implemented, should systematically make the care different, and that difference should always be better, and that better should always be measurable based on peer-reviewed evidence. Time for a little perspective. Inspiration is the easy part. What's been vexing for the last 10 years has been the implementation part of it. So we identified one such program, the cerebral palsy program in our organization, and they had been charged, they had clinical quality of care issues, and they asked me if I'd help them do research, and I said no. And they said, well, isn't that your job? And I said, you are going to be my pilot program. You're going to be the first instance of my model. And so let's just say that we made a deal, and I integrated myself into their redesign of their clinical program. So we identified all of the key stakeholders, doctors, nurses, clinical staff, administrators. For us, our EMR is EPIC, the EPIC team, the data warehouse team, research informatics team, hospital informatics team, and we involved the patients and parents through a survey. So as you might imagine, we also needed to have a project manager to ride herd, because most of these people had never met the other people in the room, which gets to that stakeholder and that varied interest. Some of them even had the same college degrees and had never met each other. Some of them had the same degrees and managed the same data set, except if you're on the hospital side, data is to be protected because we can't violate the law. And if you're on the research side, data is to be shared because that's how we acquire new knowledge. Whose data is it? So it's the same data set. We call it the EHR. So we set a series of meetings and we detailed the scope of the project, and things were going really well until we got here, the benefits to the organization and the patients, and everybody was all fired up. And then we got here. And then all of the fun of change went away in one meeting. We started to explain, oh, well, as part of this, actually, you have to change. And suddenly all those smiles turned to frowns. So the doctors had to change the way they practiced. The nurses had to change the way they practiced. The staff had to change the way they documented the care. We had altered interactions between the hospital and the research informatics team. These people didn't even know each other. Same degrees, same data, completely different philosophies around what data is for. And then we went to the EPIC team who does this for a living, rolling out. They said, we've never done anything like this. I said, okay, we're not really interested in what you've done. Just stick these new data fields that the doctors want the answers to in the EMR. So what we heard from everyone is, whoa, okay, so this was a lot more cool up here than down here. This is a lot of change. So time for more perspective. Change is hard because people overestimate the value of what they have, and they underestimate the value of what they might gain by giving it up. And that is a very important theme for the rest of this talk. So we were moving along, and we had to deal with the IRB and the HIPAA issues. And I don't have time to get into too much detail about it now, but I will tell you this was the point at which my engineering background and my simple little circle came back to haunt me, because it was in one of our meetings where we had the head of legal services and the IRB chair that I realized that what seemed so simple was actually very disruptive for a medical center. Because in about 3 minutes, I found out that I had made the head of legal services and the chair of our IRB both very uncomfortable, but for completely different reasons. It's like, okay, this is going to be a problem. So anyway, we worked through all of those, and the ultimate agreement is we had to get IRB approval to enter patient data into the electronic health record. I love that. IRB approval to document care for billing. Anyway, so we do have an overall IRB for our EHR, and in order to get access to the data to do research on it, you do have to apply for another IRB. So this does conform to standard protections. It's just a slightly different model than we're used to. So we developed the routine clinical related fields. Remember, I told you that they had been charged with improving care, and I made them standardize it based on the evidence that was available. So we put all of that in, but we did it all as discrete data, so standard data elements or data fields and drop-down data elements. Free text, computers are excellent at identifying. They are not so good at extracting meaning from it. So we tried to minimize free text. That is a problem that will go away with artificial intelligence. That's starting to happen now, but that's not quite ready for prime time. So this turns out to probably have been the secret sauce, which is we offered the doctors the chance to improve the care of those exact patients if they would only help us do this. And I talk around the country about this, and I talk to chief medical officers of other large health complexes, and almost without fail, this is the nemesis. The doctors don't really want you to tell them what to do. So this made these doctors actually want the answers. So they were not only willing, they were interested in this. So we put all of those data fields into the EMR, and we made that part of the documentation for every patient for every visit. So those were entered at the point of care. All the data was collected as part of what we now call a billable patient encounter, and it all got migrated to the data mart. So I will just summarize by saying that during this time, the young woman who was running the CP program went to a CP meeting and shared the abstract from this, and a woman with a multi-center NIH-funded clinical trial grant came running up to her afterward and said, "How did you get all those patients? I have an NIH grant, and it has taken me 3 years to collect these patients, and you got more patients in one center in 1 year than I've gotten with a grant and 10 sites." So I share this with you as an example of the potency of going from 1 or 2% of people being involved in research to everyone being part of the research that we do to improve care. So remember my hypothesis, a learning health system can be cost-effectively developed and implemented to systematically improve care and reduce costs. So here's the actual experiment. We implemented this model of EHR-supported care, and it turned out to be 131 children with cerebral palsy, and we integrated care, QI, and research. Importantly, this is none of them. It is actually, I was talking with someone earlier this morning, all these different boxes that we have for how we provide care and improve knowledge. This is not one of those boxes, and it is a new box, which actually is it's parts of all of these. And that might explain why this work got rejected at 7 journals before it got published. Because when you go for peer review, you get an expert in a box, a research expert, a QI expert, a clinical care expert, an epidemiology expert. This was not any one of those. This was a mixture of them. So for our outcomes, we looked at healthcare utilization rates and healthcare charges. So just to summarize the intervention, so they learned from every patient group during the study period, got this standardized care with evidence and expert opinion. Their routine clinical care got collected in the EMR, but as discrete data fields and elements. But we also had those physician-inspired research data built into the EMR. And what we learned is that in the past, the documentation was really only for billing purposes or if lawyers came calling, and then suddenly we realized that the data was not only incomplete, but in places it was incorrect. So what we realized is we actually want to use this data, and we want to use all of it. And in order to do that, you have to invest in someone with content-specific expertise to do quality control to make sure that the data entry are both correct and complete. It's because we have a higher purpose for what we call documentation now. So these patients also got standard care coordination, and we also compared them to a non-LFEP group who got our standard care coordination, and they got our standard of care at our hospital for this group of doctors, but not this standardized care. So same place, same doctors, same time. So this is shown graphically here. So the LFEP group of 131, we started with an initial clinic visit and we measured their healthcare utilization for 12 months going forward, and we compared that to the previous 12 months. Could being in this program improve your care? Could it lower your costs? And we had two control groups. The non-LFEP group was at the same time and almost 700 children at the same place, and we made these same comparisons here. But we also added another control group. We all are doing QI, all of us, all the time. So we needed to ask the question, well, can we move the needle? So care was getting better at our institution for these patients already. So we looked at the same exact 131 patients during the year beforehand, and we said, how much are they getting better? Because if they continue to get better at the same rate, our program has actually had no effect. They're getting better, but they were getting better because of our QI efforts, not because of this program. So to be clear, this is the LFEP group, the study group, compared to themselves a year earlier, pre-LFEP, and then compared to another group of patients with the same diagnosis at the same place during the same year. So I have a few data slides here to share with you. This just shows some demographics. This group did turn out to be a little bit younger than the non-LFEP group, and they had a little bit higher rate of being enrolled in Medicaid than the other group. So I have three main data slides to show you, and they are all formatted the same. The LFEP group is always in black on the left. The pre-LFEP group is, remember, those same patients in the year before, and the middle in gray, light gray, or medium gray, and then the non-LFEP group is on the right. So this shows in our 12 months a change in inpatient admission. So our study group had a 27% reduction in inpatient admissions. The year before, they had a 9% improvement. So it's not like there was not improvement going on, but it tripled with this program. And here is the non-LFEP group. Same year, same diagnosis, same institution. This was the incremental difference. Similar change in total inpatient days for the whole group was greatest in the LFEP group. Change in ER visits, much greater in the LFEP group. Change in urgent care visits, much greater in the LFEP group than either of the other control groups. So this is looking at utilization over 12 months in one specific group of patients. So what about the charges? So the biggest burning platform that we're all on is the cost of care, how high it is, and the fact that it's continuing to rise. So this is looking at the cost per child over those 12 months. Again, the same parameters. The LFEP group is on the left, pre-LFEP is in the middle, non-LFEP is here. So we were improving care by about $5,000 per patient per year in this group the year before, but when we put them in this program, it doubled it to $10,000 a year for inpatient charges. These look very small because these are absolute dollars, but the LFEP group also had the best improvement in ER visits and urgent care visits. And when we put all three of these together, we called these unanticipated care visits. The LFEP group significantly outperformed the others. And when we looked at total system charges for our hospital, you can see that being in this program for the 12 months tripled the reduction in the overall system charges. So if you're on a fee-for-service basis, that's bad. If you're on an accountable care model, which we are all gradually moving toward, that would be good. That's what we call profit. So this model very much plays into where the changes in healthcare are going, not where we've been. So if you're a CFO you're interested in absolute dollars per patient, but if you're a CMO, you'd be interested in programmatic changes in percentages. So this is the exact same data set as the previous slide, but expressed as percentages. 34% reduction in inpatient charges, 23% reduction in ER charges, 29% reduction in urgent care charges. And here for total charges, 25% reduction compared to these. So whether you look at percentages or absolute dollars, clearly the cost of providing the care to those children perform better than either of the control groups. So just to summarize, so in the LFEP group, there was a 43% reduction in total inpatient days, a 27% reduction in admissions, 30% reduction in ER visits, 29% reduction in urgent care visits. And correlating that with charges, this was a 34% reduction in total charges. So by the way, this correlated to $1.3 million in one clinic in one institution in 1 year. 34% reduction in total unscheduled charges, that's hospitalization, ER, and urgent care visits together. And 23% reduction in emergency room charges and 28% reduction in urgent care charges. So back to the question about, did you actually move the needle? So if we compare that to the year before, how much was the incremental change? How much did we improve the improvements by doing this? And when we compared the LFEP group to themselves the year before, the pre-LFEP group, 210% reduction. When we compared them to the 700 children at the same time who were not in this program, 176% reduction. And similar reductions here of unscheduled care charges between the pre-LFEP and non-LFEP group. So back to the model. So basically where we were is right over to here. But as several deans of colleges of medicine have looked at this and looked at it before it got published, and one of them looked at me and said, but Bill, where's the learning? Okay, this is just setting this up. The learning really had not been harvested yet. All we had done is this part. So what I'd like to share with you, though, is what the capacity of a system like this is to generate the learning and bring this full circle so that you actually can see how you've changed care and know that that change is both better and cheaper. So I'm not going to go into detail here, but this just shows the learning project. So you remember, to get the doctors to play, I said, what would you like to learn? So it would be different for you, but this was what they wanted to learn. And what I'd just like to highlight for you is that in those 12 months, enough data was generated on the questions that they have that 1 manuscript's already been published and 3 more are in preparation from 1 year at 1 center in 1 program. And in fact, 2 of them have already led to systematic changes in the care at our institution, which not only saves money and time, it actually is exposing children to less radiation. And if anyone asks, we can give them the paper, the peer-reviewed paper, to show them why we've made that change. So no insurer can deny it. No family could be disappointed or scared off by the idea that they're a guinea pig being involved in research. This is peer-reviewed evidence driving these changes. So what can I say here about the experiment? I feel like these results demonstrate that a system can actually be developed and it can be implemented in a cost-effective manner. So with all the partial FTEs that I co-opted to do this, we estimated that we spent about $225,000 in the first year to do this. But it turns out that that was only 16% of the money that we saved. So if you reconnoiter that a different way, for every dollar we invested in this experiment, the organization saved 6. That's a pretty good return on investment. So I feel like also this program has demonstrated, at least as a proof of principle, that such programs can systematically, simultaneously improve care and reduce costs. So importantly also for our evolving payment model, this is ideally suited for the accountable care model. So for those of you that are not familiar with that, an accountable care organization model is where the payer negotiates with you and says, we're going to pay you $500 a month per child. If you can provide their care for $300 a month, you get to keep the $200. If, however, you provide their care for $800 a month, you're paying. So the payer gets to know how much they spend, and the organization is incented to provide better care. Well, they're actually incented to provide cheaper care, but if you can make it cheaper and better at the same time, that would be a win-win. But this is for sure the direction in which most people believe our payment system is moving, and this model would fare well in that system. So what do I think that we've learned that might be useful for you all as you think about things? I understand you're getting ready to move into your next strategic plan in the coming months. So we learned in spades that you got to have broad-based buy-in. It just is not going to work. The clinical people, the research people, the financial and political people, it took a fair amount of effort to get everybody lined up to do this experiment. So there is a lot of change involved. This integration of research and clinical care also requires a significant amount of culture change. The major barriers here, in my opinion, are not technical. There are technical challenges, but they are all solvable with current technology. The biggest challenge that faces all of us is our willingness to change our culture around how we provide care. Yes, it's true, doctors would have to change, nurses have to change, the staff has to change, the administrators have to change. So all of this would be the investment that you would get to try and get results like our pilot suggests might be possible. So for those organizations that are both willing and able to change, I think what we learned is that there are some huge opportunities here. And I'd just like to enumerate some of them for you. So systematic improvement in care, reduced expenses. One can easily argue that you could have a market advantage for being able to publicly state to people that are coming to your hospital that you can't go anywhere else and get better evidence-based care. Here's the evidence, and oh, by the way, we are generating the evidence at our hospital, and you would become part of that. It also creates unprecedented opportunities for very deeply phenotyping biological sample collection. I didn't talk about that, but that absolutely can be integrated into all this. So genomics, proteomics, metabolomics, all of that can get migrated into that data mart. Radiology, pharmacy usage, all of that can get put together and be used to systematically improve care. So if you're interested in doing registration trials and getting FDA approval, one of the metrics that they particularly like are patient-reported outcomes. This system also feeds in beautifully to anyone that is interested in incorporating patient-reported outcomes to systematically improve care. So we're at an academic medical center, so career advancement is an important thing. This also generates a huge amount of data that basically could be handed to trainees or young people and say, you know what? Analyze these data and publish it because we've got 500 patients. This will now be publishable. In the past, we would have had 5. Now we have 500. So it will generate a recurring source of significant amounts of high-quality data that can be published. It won't publish itself, but it will provide doctors the opportunities to publish the data and generate the evidence to support the changes. So as I mentioned also, I don't want to leave unspoken also that this model is directly consistent with the emerging or evolving changes in our healthcare payment model. So there are a number of challenges going forward. Is this program scalable? Don't know. I just did one experiment in one place. Can it be successfully adapted to adult care? Don't know. Can it be adapted to surgical care? Can it be transferred to other institutions? So I'd love to tell you that I came up with all these ideas, but I think for the young people in the room, what I should reveal to you is that these and more came with rejection letters at the 7 journals where I tried to send this manuscript. So people start out not believing you. So if you really want to make change, you have to convince people that it can be done. And my hope is that this actually moves us from talking about this and theories to actually an example. And what it does is it takes the rug out of the idea that somebody says, well, you can't do that. It's like, well, actually, no, it's been done. Now let's talk about how, not if. So I do not have the answer to those questions, but what I do know, what we have learned from this experiment is these are actually easily testable questions. And in fact, I have become interested in trying to answer them. So one of the reasons that I'm here is there are people in your organization that have expressed interest in this model. I don't know, I don't think you all know whether your organization has the appetite to undergo the culture change that I've shared that I think is necessary to do it. But my hope is that at least this presentation will leave you thinking about what might be possible, how it might be possible to save money, how it might be possible to improve care, and how it might be possible to help reduce our country's expenses on health care. So one final bit of perspective, I think, is in order. Progress is impossible without change, and those who can't change their minds can't change anything. Love that. So I just want to close by acknowledging the people that have been involved. So Linda Lowe's, Gary Norris, and Amy Newmeyer were involved in the CP program management, and Peter Emby, who was our Chief Research Information Officer, and Susan Moffett-Bruce, our Chief Patient Safety and Quality Officer, were very involved in the model, and we're all interested in seeing the model expanded. So I'll just finish. This is a video of where I work. This is Nationwide Children's Hospital in Columbus. So with that, I think I'll close, and I thank you for your attention, and I would welcome comments, and I even would welcome criticism. Yes, sir.
I'll get a question. What we're doing with this. One of the hats I wear is I work with the National Organization for Rare Disorders, and we actually do registries, longitudinal natural history around patient-reported outcomes. We have about 30 of them right now, and two challenges we face I'd love to get your opinion on. One is making sure we use a common ontology for variables, and how do you address that in this, so we don't yet invent the 18th, 19th, 20th way of recording stuff. And how do you see the interface between a PRO registry or patient-reported outcome registry and an EMR like this, and what's some good first steps? Because that's our next challenge at NORD.
Yeah. So you are already multi-center, which exponentially makes it more complicated. So we did this particular experiment in one center. So when we asked the doctors, tell us what research questions you have, we made the data field. So we didn't have to deal with the fact that things might be structured differently, but the ontology problem is actually huge for multi-center. And another place that it's turning out to be very, very big is when we interact with other countries, when the FDA talks to the EMA. And I remember Steve Hirschfeld at NICHD had highlighted this to us, that at one point they had looked back and there were 9 definitions for what it meant to be a child. Okay, that's the problem. Do you remember how I mentioned that you can't measure an improvement if you can't say what you improved from? So it's not sexy, but the commitment to standardizing the nomenclature and the definition for the nomenclature is foundational if you're going to make change, because it will be uphill and you will need to convince skeptics. And so making sure that you can articulate clearly, here is where we are, here is what we've done, and here is the difference, and it is or isn't statistically significant, is critical. Yes, Lisa. I knew you'd have a question.
Thank you. So talk about how scaling. And I am mindful that you're scaling from a single program in a single, a single program in a single institution to other institutions. And almost by implication, it's the whole institution. So what about a scaling approach that would be mindful that physicians are not only change averse, physicians and healthcare teams are change averse, they're also risk averse. And if that's true for physicians and healthcare teams, it's really true for organizations. So why not scale this by doing something, for example, with CP programs in a number of different institutions? It's the idea of embedding the pilot in a broader set of institutions so that there is the demonstration to the culture that, gee, this really can work here before you try to have the whole organization embrace it.
Yes, so this this is this that we had talked about. So love that idea. An interesting byproduct of this experiment is other CP programs around the country heard about it, and they actually have started a CP network. Not exactly like this, not a learning health system within there, but this has precipitated a huge amount of interest, and there's more research being done on CP now around the country from people sharing information just kind of because they were inspired by this. But what we haven't yet been able to do is implement at their centers the same thing in CP that we've done there, but that certainly is what is envisioned here. So you can't do that in one program if senior leadership's not interested or able to do it. So even that index program at that place would have to have buy-in from senior leadership. So we're not resourced to do that, but I certainly would love the opportunity to do that.
Don Goldman from Boston Children's Hospital over here. Yeah, I'm a guest, and I wish I'd given my talk on scale up, but I didn't. This is kind of a two-part question. The first is if you could compare your framework to some other models, such as SCAMPS that was developed by Jim Locke at Boston Children's and used, talked about around the country, many potential adopters, but was a paper system. And Improved Care Now from Peter Margulis at Cincinnati Children's, which was very data digitally intense and included patients as well as the healthcare providers. And then if you could identify one change that was made as a result of learning system that drove the remarkable reductions that you saw, it probably wasn't 100 tiny things. It probably was a few big things. Could you identify with that?
Yeah, so the first group that you mentioned I can't really speak to, but the Improved Care Now I'm much more familiar with. So that was a quality improvement effort. So this is, it has many of the features here, but it was at the origin multi-site, and it did not have the features of this where the questions got asked. This is where the care got directed and collected and best practices shared. So this is not conceptually identical to a quality improvement network, because this actually incorporated the local questions within a given program that the physicians came up with. So they share some similar features, but they're not conceptually identical. And then with regard to your question about what the incremental change was due to, I don't know that I can say that it is one thing. I mean, these people did get standardized care. They did get somebody hounding the data to make sure that the data got entered. So I think that their care coordination was more meticulously observed and managed. But I can't speak that one particular set of data was the driving force there. So that question has come up multiple times. That like there must be one thing that you did. I don't know that I can say that there was one thing.
I'll just throw in one comment too. There's actually a long-running example of this, which is the Cystic Fibrosis Foundation's registry. That's multi-site, multi-center. I think what's really nice about what you're doing here is you're actually building it into the regular clinical flow, which CF has still got separate data entry on there, but I think there's no question that that hasn't improved the lives and care of these patients, and it can be done across multi-centers.
Yeah, so that's an excellent point. So I actually got invited to go to the CF Foundation's research meeting this past year, and it was stunning how well organized they are as a community. So they're separate from the clinical care providers, as you point out, but they are so potent a force in improving care and controlling costs that it is a wonderful model. If I had $3 billion, I'd love to emulate it. Agreed. But the margin does help the mission. Anything else? All right, well then, thank you very much.